Hi, my name is Brant Oelschlager, and I'm here to discuss esophageal surgery in the United States and whether it's time for accreditation. I'd like to thank SAGES as well as Dr. Silla and Dr. Jackson for inviting me to give this talk. It's certainly very timely as I recently led a retreat for SAGES leadership to advise them on the future of foregut surgery. And this was a major topic of our conversation. I have nothing to disclose except that I am a full-time esophageal and gastric surgeon. There are many reasons for and against. I've listed a few here. And of course, when we talk about accreditation, we are implying regionalization of care to specialized centers. Certainly reasons for our esophageal surgery is mostly elective. There are certainly probably enough high volume centers to care for these patients. There's a possibility for getting better overall outcomes, as we probably all intuitively know. And the best may even get better if we regionalize care. And this is frankly what many surgeons want in SAGES, at least according to our recent process. There are many reasons against as well. There are surgeons, many general surgeons and thoracic surgeons who perform a low volume of esophageal surgery and often get very, very good outcomes. Patients need to travel away from support systems. It may disrupt their care teams that are local. And even less experienced low volume surgeons are doing emergencies and maybe seeing low resource patients. So if we take away some of that care, we may be getting worse outcomes for already disproportionately affected disenfranchised groups. And frankly, many surgeons, probably many in this room, don't want it. So what should we do? The bottom line is we know the main issues. There is evidence for rare complex procedures. There are countries doing it already with improved outcomes. We can mandate it or let it happen naturally. And of course, if we did do it, where would we draw the line? It is a rat's nest for organizations like SAGES because there are constituents for and against this idea. And we could spend all evening on this topic, but let me try to hit the high points. Obviously, in esophageal surgery, there's a spectrum of disease from highly complex and frequent procedures to less complex, very frequent procedures. And where would we draw the line, as I've attempted to here, is a big question. But let's be clear, this idea of accreditation has been with us for a while. You see here in general surgery, we have volume numbers for residents training, as well as in cardiothoracic surgery. The Fellowship Council has recently designated foregut fellowships with increased numbers of procedures within it. Thoracic surgery and the Fellowship Council has done the same by naming the number of cases for accreditation. So as a means of review, there is compelling evidence for concentrating complex operations in higher volume centers or surgeons' hands. Many of you are probably familiar with Burt Meyer's study about 2 decades ago, showing this volume relationship with better results for esophagectomy in higher volume surgeon and hospitals. The same has been shown for gastrectomy. This study done almost 20 years ago, looking at New York hospitals, showed the same effect. And many countries have gone the route of accrediting centers and regionalizing care. About 20 years ago, England did it, as shown in this slide. Within about the first 10 years, it pretty much weeded out low volume centers doing less than 20 esophagectomies, as is shown in the blue bars on the bottom. And over that same period of time, there was a dramatic drop in mortality for this procedure. It is already happening in the United States without accreditation. Esophagectomy is increasingly done at high volume centers and the mortality is dropping. Now, this drop in mortality may not be entirely due to accreditation and regionalization, but this regionalization is having a positive impact for sure. However, patients aren't always buying it. This slide shows that 2/3 of patients in California a few years ago were getting their gastrectomy at the center nearest to them. And if they didn't get their operation at the center nearest to them, and some of them did get treated, did leave their region to get treated at a high volume teaching hospital, but many left their region and bypassed a higher volume hospital than they ultimately got care at. So it seems that people either aren't aware of this volume outcome relationship, or maybe they just don't care. As a result, the majority of gastrectomy and esophagectomies in this country still are done in low volume centers. And the often kept dirty secret is that those least likely to receive treatment in a high volume center are the old, those who have Medicaid, and the African-American population. So where do you draw the line? This study here compared achalasia treated in low, intermediate, and high volume centers, and compared to high volume centers, lower volume centers had increased complications, open procedures, length of stay, and cost. Not surprisingly, if you go and look at GERD surgery, you'll find similar trends of increased complications, even mortality, and increased cost of care. So what are we to do? I will tell you the SAGES decided in this retreat process not to pursue organizing accreditation of esophageal surgery centers. I'll tell you what I think. If you ask me if accreditation for esophagectomy and gastrectomy should be pursued, I'd say probably yes. But perhaps we should have tiers of accreditation to take into account regions that lack proximity to large urban centers. If you ask me the same question about unusual, complex, benign diseases like achalasia, printed diverticulum, maybe even redo or complex hilar hernia repairs, I'd say probably we at least should pursue or consider having some guidelines and strong recommendations for centers that perform these operations. How about for the higher volume GERD operations? I still say, yes, it's worthwhile pursuing, but with a bigger caveat that we need standards attainable by dedicated non-urban surgeons, because many of them are doing these operations very well and are serving a need for patients without access to an urban center. But we might all benefit from following expected pathways that might occur from accreditation. So we can do it, or it'll be done to us, but admittedly, if nothing's done, the pace organically will be slow. Patients or governments will regionalize care by official or unofficial means. I think the biggest question is, if we do pursue it, how are we going to make sure we provide better care to marginalized patients that currently have the worst outcomes? And could accreditation improve this process? Thank you very much for the opportunity. I look forward to the discussion.